Welcome to today's webinar, Cognitive Clarity, Understanding HIV-Associated Neurocognitive Disorder, also known as HAND, Alzheimer's, and the importance of accurate diagnoses and HIV care. My name is Shauna Cooper, and I'm the Director of Programs at Ribbon. On behalf of our team, I want to thank each of you for taking the time to join us today for this important conversation. At Ribbon, our mission is rooted in addressing racial and social disparities in health and wealth, particularly for communities disproportionately affected by chronic health conditions, including HIV. Through initiatives like the Ribbon Organization Center, better known as ROC, for Aging Positively, we are committed to empowering organizations and individuals with the tools, resources, and support needed to create sustainable, equitable outcomes for those aging with HIV. Before we begin, I would like to make a few quick housekeeping items. This session will run for about approximately 1 hour and will include time for a Q&A segment at the end. If you have questions during the webinar, please enter them into the chat, and if time permits, we will invite people to unmute themselves and ask questions or offer a comment to today's panel. Lastly, this session is being recorded. A notification with the replay link will be sent to you following this session. I'm honored to be here with you all, to include Ribbon staff. I'm confident that today's discussion will provide valuable insights to help us drive progress. With that said, it is my pleasure to turn things over to Denise Straighten, Program Associate with Ribbon's Rock for Aging Positively initiative. Denise will introduce today's topic and our incredible panelists. Denise, the floor is yours. Thank you.
You're on mute, Denise.
Of course I am. Why wouldn't I be? Okay, and now my screen is frozen. But I want to say that this topic is about cognitive health, and it's a vital yet often under-recognized aspect of care for people living with HIV. Conditions such as HIV-Associated Neurocognitive Disorder, HAND, and Alzheimer's disease can profoundly impact quality of life, affecting memory, focus, and daily functioning. Many individuals face personal challenges such as stigma, fear of misdiagnosis, or limited access to cognitive health resources, making it even more critical to address these issues. HAND and Alzheimer's are frequently misunderstood or misdiagnosed in relation to one another, underscoring the importance of accurate diagnosis and comprehensive care to improve outcomes and provide the support needed for those most affected. I'm going to try to move it forward with my arrow, and now, okay, let's see what happens. Okay. I just want something, every time I hit the back button, something happens. So what I wanted to say before we move forward to the next slide is today's training will explore neurocognitive challenges, like I said, and the critical role of accurate diagnosis in care. But we know that certain topics covered today might resonate on a personal level with some participants. My mother had Alzheimer's. I shared that with the speakers earlier. So we encourage you to prioritize your well-being throughout the session. And if at any point you find the content emotionally challenging, please feel free to step away as needed. And this is a place for thoughtful engagement and self-care. We want to make sure that we're always looking out for ourselves. So what we want to do today is we're going to have our speakers define HAND, its risk factors, and how it manifests in people living with HIV. We want to identify some key similarities and differences between HAND and Alzheimer's disease to improve diagnostic precision. And we want to recognize the lived experience of people with HIV navigating cognitive health challenges. So our first speaker today is Kate Pierce. She's the Director of Dementia Support at the Alzheimer's Association of Greater Michigan Chapter. Kate is a social worker with a master's degree in social work from University of Michigan with a focus on adult development and aging. Ms. Pierce has experience working with older adults and other specialty populations and is skilled in program development, public speaking, and social services delivery. And our next speaker is Sylvester Askins Jr. He's an HIV advocate and founder of Moving Forward Consulting. Sylvester has been living with HIV for 33 years and has recently joined the NWPC staff after serving on its board. Previously, he was a director of health programs at the Urban League of Hampton Roads, where he managed the Ryan White program. Sylvester is also the founder and CEO of Moving Forward Consulting, a company dedicated to helping people living with HIV access the resources they need to achieve their employment goals and long-term economic security. So before founding Moving Forward Consulting, Sylvester worked at the E-Dependence Center in Norfolk, Virginia, where he coordinated the Ticket to Work program funded by the Social Security Administration. And in this role, he assisted individuals with a wide range of disabilities in preparing for and securing meaningful employment, which is a noble thing. He's also trained as a community work incentive coordinator and a benefits counselor. So you hear from Sylvester immediately following Kate. So Kate, I give you the floor. I'm going to stop sharing so you can share.
All right, thank you so much for that warm welcome. As she said, my name is Kate Pierce. I'm a social worker, and I work for the Alzheimer's Association Michigan chapter in our HIV Supportive Services Program. I'm trying to make sure you don't see a little gray bar on my screen. Do you see that? Hopefully not. Okay, perfect. So we're going to talk a little bit about aging with HIV.
We do see the bar. It's blocking the last sentence on your slide.
Ah, poops. How about we're going to give it a couple seconds to see if it goes away. We know that when we're aging with HIV, that people living with HIV tend to develop age-associated illnesses faster or younger than people without HIV. And there's multiple reasons why we think that might be. It could be because they tend to have more chronic illnesses, just in general. It could be chronic inflammation from the HIV itself. It could be effects of HIV medications, both medications people are taking now, as well as legacy effects of some of those earlier more toxic medications. And then also just engagement in different health behaviors. We know that people living with HIV are more likely to use alcohol, tobacco, other substances. And what this all means is that 50% of people living with HIV in their 50s have 2 or more additional health problems, things like cardiovascular disease, depression, non-AIDS defining cancers, and that's more than adults without HIV that are more than a decade older, which means I showed someone's chart with HIV and kind of their other chronic health conditions. We would think they were someone much older than they are. And one of those things that we know that people living with HIV are more likely get is cognitive decline or thinking and memory problems. In fact, we know that people living with HIV are 5 times more likely to experience thinking and memory problems than those without HIV. And well, 5 times more likely doesn't mean a whole lot unless we can compare it to those without. And so what that means is 60% of people living with HIV over the age of 50 or living with HIV for 15 or more years self-report that they have concerns about their thinking and memory. So more than half. Interestingly, more than a third haven't discussed this issue with their medical provider. And for me, that's a big deal because that means if we're not talking about it, we can't treat it, we can't reassure you about it, we can't investigate it, we can't do anything. So I am so grateful that groups such as this are opening these conversations up so we can talk about what's normal, what's not normal, what are the different things that we might need to be concerned about so that we can begin to address them. So why? Why do 60% of folks living with HIV that are 50 plus or have been living with it for 15 years say they're concerned about memory and thinking changes in themselves? Well, there's two main reasons. The first is that we know that people living with HIV tend to have a higher than average number of risk factors for things like Alzheimer's and other dementias. Those are things like diabetes, depression, other chronic health issues, HIV being one of them. But we also know that they're at risk for something called HIV-Associated Neurocognitive Disorder, which, as the name suggests, only people with HIV get. So we're going to talk about both of these things. But before we do, let's get a baseline. What are normal age-related cognitive changes? Because as we age, we all might see some minor changes in our thinking and memory, just like we all see some changes maybe in our hair color graying or our skin getting a little more wrinkly. We do see some minor changes in thinking and memory. And in normal changes, we would expect maybe some slight slowing of how quickly you can remember information or how quickly you can, find the solution to that problem, balance that checkbook, whatever it might be. Some maybe slowing of our attention or needing less distractions to pay attention to something, or how quickly we process information. My favorite example for that is, you got to turn the radio down when you're looking for the house number when you're driving. But these changes should be minor. You should be able to work through them or around them, and they shouldn't significantly impact kind of your day-to-day life. You remember that person's name, you get to the answer to the problem. It just might take you a little bit longer. It's when changes in thinking, memory, and other brain functions affect daily life. That's when we call them dementia. And dementia is not a normal part of aging. Dementia is also an umbrella term. It's not a specific diagnosis. It just tells us that you have memory loss that's significant and that interfere with daily life. It has to be in 2 or more areas. It has to be 2 or more standard deviations if you want to be very technical, away from your normal. But there are lots of different things that can cause dementia. So I almost like to think of dementia as kind of like saying cancer. It gives you kind of a category, but it doesn't tell you the specific change that's happening in the person's body. So on your screen here today, things like Alzheimer's, Lewy body dementia, vascular dementia, frontal temporal dementia are all types of dementia, just like there are many different types of cancer: breast cancer, prostate cancer, skin cancer. And just like different cancers have different treatments, have different, progressions, have different, mortality risks and outcomes, all the different types of dementia have different progressions, have, different symptoms, etc. What's also important to note is we realize that it's possible to have more than one change happening in your brain. So there's also something called mixed dementia, and that's just saying, there's more than one thing happening in your brain. Alzheimer's disease is the most common type of dementia. About 60 to 80% of dementia are Alzheimer's disease. And so that means that, unfortunately, sometimes Alzheimer's and dementia are used interchangeably, even by people who should know better. But Alzheimer's is the specific name of the change in your brain. It causes nerve cells to die, leading to shrinkage in the brain. And it's that shrinkage that causes changes in memory, thinking, and behavior that are characteristic of Alzheimer's. Memory loss, and specifically short-term memory loss, is the most common first symptom of Alzheimer's disease. But Alzheimer's is a progressive disease, and if nothing else gets you first, it is ultimately fatal. Pre-COVID, we were the 6th leading cause of death. Post-COVID, I haven't seen those numbers kind of rerun, but I would be shocked to hear if we had fallen out of the top 10. And age is the #1 risk factor for Alzheimer's disease. Alzheimer's disease is also a continuum. And what that means is that you don't go to bed, with normal brain function, and then you wake up with Alzheimer's dementia. We now know that changes from Alzheimer's are happening in your brain for years to decades before you have outward symptoms. And those symptoms progress over time. So you can see here on your screen this kind of continuum of there's changes in your brain, but you wouldn't notice. There's changes, they're noticeable, but they're not severe enough to be called dementia. And then there's dementia from Alzheimer's disease. So only this purple part of what you see on your screen right now would fall under that dementia umbrella. Everything else would be kind of outside of it. And then prevalence. As I said before, age is the number one risk factor for Alzheimer's. So as you see here, risk increases with age. For people 75 and plus, 11% have dementia. By 85 plus, it's 33%. However, we know that there are some groups that are more likely to develop Alzheimer's and other dementias than others. So as you see on your screen, African Americans, Black Americans are approximately twice as likely to develop Alzheimer's compared to whites, and Hispanics are about 1.5 times more likely. Now, does this have to do because you have more different melanin in your skin? Of course not. A lot of these risks we think are due to, again, some other health conditions that increase risk, like increased risk of diabetes and cardiovascular disease, but also things like systemic racism, less access to medical care, or being unwilling or afraid of accessing medical care, socioeconomic burdens, etc. So what is HIV-associated neurocognitive disorder? I'm going to call it HAND from now on, just for brevity's sake. It is itself a collection of thinking, motor or physical, and mood problems experienced exclusively by people living with HIV. If you've been in the field for a while, or you've been living with HIV for a while, you might have heard it called AIDS dementia complex in the past. We're moving away from that name. And the use of modern HIV medications has greatly reduced the severity, so kind of how far HAND progresses, but not the incidence or how many people are getting HAND. And again, for HAND, exclusively HAND, so taking kind of Alzheimer's and other dementias out of it, about 50% of people living with HIV will experience HAND in their lifetime. However, only about 25 to 35% will experience impairment in kind of day-to-day life. Because again, HAND, like Alzheimer's, is a continuum. We'll talk about that in a moment. Here on the screen are the symptoms of HAND. They fall into these 3 categories. So concentration issues, memory concerns. The memory concerns here are more in what we call working memory, or the memory that you use to like manipulate information in the moment. So an example here would be someone telling you their phone number. Oh yeah, you want to put my number in your phone. My phone number is 555-6767. That's you in your head going 555-6767, 555. That's working memory. You're actively like manipulating it, or doing mental math is another good example. Planning and organizational problems, and then decision-making issues. Also some mood components, potentially, motivation issues, irritability, anxiety, depression, sleep changes, and even mania or big mood swings. And then physical changes, so slowed movements, tremors, poor coordination, imbalance with walking. And as I said before, HAND is also a continuum. Now, to be very honest with you, these stages or categories are really only used by researchers, because as asymptomatic neurocognitive impairment implies, it's asymptomatic. You don't see changes in your day-to-day life. So if you're not going to your doctor and saying, gee, doc, or your provider, I have concerns about my memory or my thinking, they're not going to test you for it. So yes, if we took you to a research lab and gave you some memory and brain tests, we could possibly, see that you have some changes. But that's really not being diagnosed kind of out in the real world in the clinic. And so that's, again, why we say 50% of people will experience HAND, but only 25 to 30% are really going to notice it day to day. And that's because they're going to fall in one of those latter categories, either mild neurocognitive disorder or HIV-associated dementia. So you can see there's that continuum, that line, just like for Alzheimer's disease down below. And again, only the purple part of that continuum is going to fall under that dementia umbrella. And happily, only about 2% of folks with HAND will get to that HIV-associated dementia stage in kind of current day and age. Most people are going to stay in the more milder stages. So, quick and dirty, how is HAND different from Alzheimer's disease? Well, unlike in Alzheimer's disease, in HAND, the main symptom of HAND is rarely the inability to remember. When I go out and I talk to audiences and I say, you know, what do you think of when I say Alzheimer's disease? People say repetitions, forgetfulness. That's not going to be the flavor of memory loss in HAND. It's much more likely to be that it's harder to learn new things, but you can do it. You know, it takes more time to kind of pull things out of your memory, but you can do it, which is different than Alzheimer's disease. The other big change is that those motor symptoms are present early. We know that there can be walking changes, balance changes with Alzheimer's disease, but that comes many, many, many years into the disease process. With HAND, it's often a first symptom. And then this is just another kind of way of saying that same thing, frankly. The other big difference is HAND tends to stabilize. So again, people don't get to that dementia severity. Alzheimer's disease will always get to that severity if nothing else gets you first. Again, the different flavors of thinking problems. The mood symptoms are honestly very, very similar. And then when those physical changes happen is also different. And this is what I mentioned a little bit earlier, that there's been some great improvements in kind of the CART era of severity of symptoms. We haven't gotten rid of HAND. It's kind of affecting as many people, but it's affecting them at a lesser severity. So the HIV-associated dementia pre-CART was that purple. So you see that on the left-hand side of your screen was 17% of folks would get to that dementia severity. Now in the post-CART area, it's only 2%. Again, mild neurocognitive disorder, that kind of middle where it's noticeable, you see it in your day-to-day life, but you know, it's workable, work-aroundable, is 10% to 12% now post-CART. Because again, we've moved people up from the HAND, the dementia, and then a lot more people are now kind of asymptomatic. We can see it on, you know, formal tests, but they don't notice it in day-to-day life. So really exciting things. It's important to say that we really don't know a ton about HAND prevalence by race. In general, we assume that people of Black or Latinx heritage are at increased risk, but truly there haven't been that many studies, and the studies that we have had are unfortunately, very, very small number of participants. And because there's a lot of different baseline, you know, other contributing factors that we know can affect dementia risk, we haven't really been able to tease it apart very satisfactorily yet for HAND. The risk factors we do know that for sure increase risk for HAND are age, so being 50 or older or living with HIV for 15 years, having a lowest CD4 count. So at any point in kind of your HIV diagnosis, if you've had a very low CD4 count, that will increase your risk. Having a low current CD4 count is going to increase your risk for HAND. The good news there is if we can boost it back up, you might see an improvement in your symptoms. Having a currently poorly controlled viral load. So again, to me, that's a positive. That means that if we can control this, why is this? Oh, sorry. Trying to get rid of my stupid black box again, guys. If we can, you know, increase your viral load suppression, then we can potentially reduce some of the symptoms of HAND. And then some of the same risk factors that increase your risk for other dementias, things like high blood pressure, diabetes, substance use disorder, high cholesterol, all those increase your risk for dementia too. And then Hep C. So I'd like to take just a couple minutes to talk about diagnosis. I have 3 more minutes by my count. And I want to say, first and foremost, I am not a clinician. I am not someone who should be diagnosing dementia, but I can tell you what you should be looking for. And the one thing that I think is so important is to know that dementia and HAND aren't the only causes of memory and thinking change. And I think that the fear of hearing that's what it is keeps getting people from going to their physician, their provider, and investigating the cause. And there are so many things that are potentially treatable, reversible, that if you just went and we looked for, ruled out, ruled in, we could really improve quality of life. So other causes of things that kind of mimic dementia and HAND are depression, medication side effects, even medications you've been on for many, many, many years. As we age, our kidney clearance changes, our liver function changes, our body composition changes. And so medications we've been on for many years don't clear in the same way. And so we can start to have side effects from them. Thyroid problems, vitamin deficiencies, substance use, sleep disorders. Sleep apnea is a huge cause of memory problems, both in the short term and the long term. So please, 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 please. If you're someone that's on this call and saying, oh gosh, I have this, that, and the other that Kate's talked about, please know that there are many other things that can cause those symptoms. And if you get one thing from me talking today, I hope it's that you feel comfortable going to your doctor, your provider, and getting to the bottom of it, because it might not be dementia or HAND. So when we talk about diagnosing HAND, unfortunately, there is no single kind of diagnostic biomarker or combination of markers. I can't draw your blood, I can't image your brain and say for certain this is HAND or it's not. It's a diagnosis of inclusion, which means I need to rule out everything else that could possibly be causing your troubles before we call it HAND. So I've got to rule out all the things on this list. I've got to rule out, your being, your viral suppression being poor. I need to rule out your CD4 count being low as a possible cause. I need to, rule out medication changes. And a big key for diagnosis is some sort of neuropsychological, it's a fancy way of saying thinking and memory test. If you are a clinician or know someone who is, these are two great resources for folks that are our diagnosticians. So it's the HRSA guideline for HIV/AIDS clinical care. I know someone I saw in the chat mentioned that UCSF, they just call it brain health now. HRSA still uses HAND, so that's what we use. And then there's also a guide through UCSF that talks about HIV-Associated Neurocognitive Disorder and management and diagnosis, and that's from 2017. So as you can see, we're probably due for an update, and I'm really excited that groups such as this are kind of moving the conversation forward and putting some pressure on HRSA to do so. Alzheimer's disease is also, unfortunately, a diagnosis of exclusion. Although there are some markers of Alzheimer's that can be seen in spinal fluid and brain imaging, specifically called an amyloid PET. These are not always done for everyone. Kind of in the non-HIV world, people aren't super comfortable with spinal taps. I know those tend to be done a little bit more in folks living with HIV, so that might be something that's available, but these are also very expensive. So sometimes that is also a barrier, just insurance coverage. The amyloid PET itself is only available mostly in like a research setting. That's not often available in clinics, no matter what your insurance is. But this is a really exciting time in the Alzheimer's field because we are very close to identifying and getting FDA approved some blood-based biomarkers, which will help with diagnosis. Because as you'll notice, HAND's a diagnosis of exclusion, and Alzheimer's is a diagnosis of exclusion. So if I have to rule both of one out to get the other, but I can't rule one out except for ruling out the other, it becomes kind of a chicken and an egg thing. It also utilizes neuropsychological testing, those thinking and memory tests. And truthfully, a good diagnostician is going to be able to recognize the pattern of stress in your brain, the types of thinking and memory challenges that you have, and they're going to be able to give you a pretty good diagnosis of HAND versus Alzheimer's disease. The challenge is, how do we find those folks that are well-versed in both of these? And that's a challenge. And that's something, again, that we as professionals in this field need to be raising up that concern and making sure that there are trainings available for folks. Last but not least, I know I'm a couple minutes over, I'm sorry. Why do we bother determining if it's HAND, if it's Alzheimer's, if it's something else? Treatment differences. HAND, if we treat your uncontrolled viral load, if it's applicable, or other comorbid issues, that might actually reduce or eliminate symptoms. For MCI, which is just a pre-dementia form of Alzheimer's or any other dementia, we have medications. They're not going to stop change. They're not going to reverse the changes in your brain, but they're going to help slow progression of symptoms and improve quality of life. Future planning. Alzheimer's disease is progressive and ultimately fatal. While cognitive decline in hand, most of the time, 98% of the time, give or take a couple percent, depending on what study you look at, doesn't reach dementia severity. Those people are going to need very different supports kind of moving forward. So, what we need to get in place, what we need to encourage people to get in place, how we are going to educate about what to expect to family, caregivers, the patient, is going to be very different depending on that diagnosis. And frankly, a diagnosis of HAND hopefully is going to be a reassuring that hopefully it's not going to get worse. You're going to be part of the lucky 98%. That's important for folks. Again, power in naming that problem, giving the opportunity to find and learn from others with the same diagnosis. It's going to open up ability to participate in research, and then also open up potentially new and different supports. Really, really briefly, as I said, I work for the Alzheimer's Association. What's very important to me is that everyone knows that the Alzheimer's Association is really the Alzheimer's Disease and Related Disorders Association. That is too long for business cards. But what it means is that we want to support anyone with thinking, memory, brain changes for any reason, HAND included, because we cover kind of the whole gamut of reasons for cognitive change. And then these are some of the services we have: a helpline, support groups, education, et cetera, et cetera. And you'll get a copy of my slides later, so I won't bore you with that. Thank you so much for attending. And I look forward to questions once we're done from hearing Sylvester's experience. So thank you so much.
Thank you, Kate. And even though it was a minute or two over, it was very impressive. And we don't worry about minutes when it comes to this kind of information. So now I'd like to introduce you again to Sylvester Askins, and he's going to share his lived experience.
Good afternoon, everyone. First, I want to say a very special thank you to Linda and all the folk at Ribbon for giving me this opportunity to share my experience. Secondly, I want to say to Kate, that was an awesome, awesome presentation, and I can identify with so much of what you said during that presentation, and it answered a lot of the questions that I have. I'm a person living with HIV for about 34 and a half years now. I live just outside of Norfolk, Virginia, and for more than 3 or 4 years, I had been noticing some issues around memory and cognition, I tried to talk to my primary care physician about it, and he kind of shrugged it off. But one thing about living with HIV for as many years as many of us have, we know our bodies and we know when something is not right. And I knew within my heart of hearts that there was something going on with me. So I continued trying to talk to my primary care physician about some other aging dynamics, and he just wasn't hearing me. And I'm one of those people that if you can't give me what I need, then I need to find someone who can. So a new primary care medical group came to the Norfolk area, and they specialized in elder care. So I went there beginning September of last year. In my second visit with the new doctor, I explained that I was having some issues around cognition and memory, and she was very open to what I was saying, and she immediately said that I needed to be assessed. I completed the SLUMS assessment, which is a good tool for recognizing early mild cognitive impairment. I scored a 20 on that assessment, which led her to say that I need to put you on some medication, and I want you to reach out to the Alzheimer's Association. The medication that she put me on was something called donepezil. That was something that my body did not deal with very well. So I went back to her and told her that that medication did not work well with me. So she then put me on something called memetine, which was not quite as harsh, So I continued taking that for a while. Part of my issue has always been getting a good diagnosis and then also trying to get people to understand what has been going on with me. As many of you know, those of us living with HIV, for long-term survivors, it has been suggested that at some point we should see a geriatrician to get a complete geriatric workup. I was unable to get that in Norfolk because there was no geriatrician in the Norfolk area who had education and experience both in geriatrics and HIV. But I have a wonderful friend that works at Johns Hopkins, Dorcas Baker. Many of you will know her. And I reached out to her in frustration. She said, Sylvester, there's someone at the Pratt Clinic. I'm going to see if you're able to get in to see him. So I was able to get in to see a geriatrician at the Pratt Clinic. Now I had to go all the way from Norfolk to Baltimore to be able to get this service, but I was determined that I was going to get what I needed. So in my geriatric workup, I shared what had been going on. I shared the results of my slums assessment. So he ordered neuropsychological testing for me. However, that system or that particular group was about 9 months backlogged. So I wasn't going to be able to see them until last September. So I accepted that and I went back to Norfolk and started doing what I need to do for myself. But much of what was going on with me was that I was having issues with memory. I still work full time. I do a lot of webinars, a lot of facilitation, and I'm in a lot of meetings. And I was finding that I was not able to recall things that was said in meetings, recall accurately conversations. I had to start using an AI companion when I was in meetings so I'd be able to go back and see and understand what was being said. Luckily, I do want to say a thumbs up to the National Working Positive Coalition because my supervisor, Mark Misrock, has been very, very accommodating to me. And that makes a really, really big difference when you're going through something like that you have an employer that is willing to listen and be accommodating to your particular situations. I also have issues with spelling words that I used to be able to spell all the time. And I have particular challenges with spelling words that have double consonants. I can't remember if it's going to be one or it's supposed to be two. Many times I have issues with leaving my doors unlocked. I come in the evening, if I have something in my hand and I can't lock the door right then, once I put it down, I will forget to go back and lock the door. There have been several times when I have left pots on the stove. I have turned on an eye on my stove, and I thought that I turned the back burner on, but I turned the front burner on, and there was a handle over the front burner, and I picked up a hot pot before. I went to church one Sunday, and I left a pot on the stove with the eye on. And by the grace of God, it didn't start a fire when I got back home. The pan was messed up, but my house was safe and I was safe. I have some temporary, really, really quick moments of confusion sometimes, and it's really, really very, very frustrating. I live alone. I don't have a spouse. I don't have children or grandchildren. So this is something that I'm pretty much walking through by myself. But I'm determined to stay independent and to do as much for myself as I can for as long as I can. One thing that I really, really want to stress to you guys, though, is the fact that when I started allowing myself to be vulnerable and to share with people what was going on with me, people were always telling me, no, you're wrong. No, it's not that. You're just getting older. Like, these things happen. And it's really, really frustrating. It's hard enough when you realize that you're going through something like this and then you open up and you become vulnerable and you try to share what's going on with you, and then people shut you down as if they know better what's going on in your mind and in your head than you do. And it used to make me very, very angry, make me very, very upset. And I have to be honest, I stopped talking to a lot of people about what I'm experiencing because, and I believe they're saying what they're saying out of love because they don't want to think that something like this could be happening to me. But I don't have that luxury. I can't stick my head in the sand and say, oh, this will go away or I'll deal with it later. I have to deal with this right now because it is my reality. But getting back to diagnoses, I contacted the local chapter of the Alzheimer's Association, which is the Southeastern Virginia chapter of the Alzheimer's Association, located in Virginia Beach, Virginia, became an Alzheimer's champion, and they had me go and man a table at an AARP event maybe about 8 months ago now. And while I was there is an awesome program at the Glennon Center at Eastern Virginia Medical School that specializes in brain disease and Alzheimer's. I had known Dr. Okrabi in the past. I was initially on a community advisory board for the AHEAD study, which is an Alzheimer's study that is particularly looking at populations of color. And I had tried to get into the study. However, because I was taking antiretrovirals, I was not eligible for the study. Me being me, I got frustrated because it was not inclusive of people living with HIV. So I kind of stepped back. What I came to realize later on that the reason why it was not inclusive of us is because the drugs that they were using had not been tested on people taking antiretrovirals. So I had to step back and say, okay, Dennis, Sylvester, excuse me, don't be like that. So like I said, I talked to Dr. Okrabi's office, a young lady from his office, a researcher, and I told her my situation. She said, "Don't worry about it." She said, "I will get you into our program." About 2 weeks later, I got a call from them. I was able to get in. I did my initial memory testing, and then they scheduled me for a brain MRI and some more in-depth memory testing. My brain imaging did not show any amyloid plaques, which was wonderful. However, my memory testing did also show that there was some mild cognitive impairment. So I've now been rescheduled for neurocognitive testing or evaluation in February of next year here in Norfolk. A lot of mine has been for some frustration in what's happening with me. I've been dealing with this thing for 34 years now, but by the grace of God, I've never been really, really sick. But aging, there's no manual for aging, and so many of us have so many other comorbidities. Adding just one more thing onto an already full plate has been really, really very frustrating. But I've continued to try to keep a positive attitude. I now have signs up in my house. At my front door, I have a sign that says, "Don't forget to check the door." I have a sign that says, "Don't forget to turn the stove off." I have signs that say, "Don't forget to take your medicine." My medicines are blister packed because I can get up in the morning at 8 o'clock and I can take my medicine. And most days at 11 o'clock, I am unable to remember if I actually took my medicine or not. So the blister pack is a way of quality assuring that I have taken my medications when I was supposed to take them. Like I said, I sometimes have momentary bouts of confusion. I was driving one day in my neighborhood and I was coming to this large intersection. And just for a nanosecond, I'm like, which way am I supposed to go? And that was frightening for me. And I'm realizing because of all the stuff that's going on with me, I'm now not as confident when I'm driving, particularly at night, as I used to be. I find myself being a little bit more irritable, and I have difficulty learning new things. I can learn them, but it takes longer. Part of what we do at the National Working Positive Coalition is that we do a lot of webinars, and all of our webinars are scripted because the information that we do is so dense. We want to make sure that we do it the exact same way every time. Many times before the webinars is my responsibility to go in and to update those transcripts and those manuals to make sure they're correct. And I find myself going over them 4, 5, and 6 times sometime before I'm even slightly confident that what I've done is correct. And that gets to be really, really frustrating. And my boss has been very good about it. He understands that he allows me to take my time, but it becomes more and more frustrating because each time I look at it, I find something that I didn't see before that's right there in front of my face. And it can really, really, really get to be challenging. I also find that like I said, I live alone. I'm an only child. I don't have brothers and sisters and close family members. And I've always been kind of a loner, but I find myself tending to want to isolate more now. And I really, really know that that really, really is not a good situation for me. So sometimes I try and push myself to do more things. Like a lot of us, I travel a lot for work. But when I'm not working, I find myself isolating in my home, and I find myself not letting people in. My very good friend Vanessa Johnson, who I believe is on this call, always says to me, Sylvester, there are people who love and care about you, who want to help you, but you've got to allow them in. And that's been kind of an issue for me, but I'm really, really trying to work on that. Getting back to diagnosis, I would share with anybody on this call, if it's you or someone you love and care about, if they're finding that they're having some issues, I would encourage you to uh, help them understand it's really, really important to go and get diagnosed. Don't let anyone tell you what's not happening with you. Go and get the professional type of assessment that you need to be able to understand what's going on with your body. Also, I said earlier that I am involved with local chapter of the Alzheimer's Association in my area. I was just elected to their board. I had my board orientation yesterday, and it's been a really good asset and a good outlet for me to be involved. So I would encourage anybody who thinks they have issues around memory or cognition to definitely reach out to the Alzheimer's Association in your local area. They are wonderful people. They're really, really understanding people, and they're there to help us in any way that you can. I would also say, please, please, please don't isolate. Find 1 or 2 people that trust you and that you trust and that you listen to, and allow yourself to be vulnerable with them, and help them to understand, while you might not, because of your love for me, you might not want to accept this is what's happening to me, but please understand and hear me when I say that there is something going on. The neurocognitive testing that I'm waiting to get done now, they told me they want to try to distinguish whether this is actually Alzheimer's or whether it's HAND, which is why I'm so appreciative of the presentation that Kate just did, because I see so many of the similarities, and I really, really would like to know which of the 2 things it actually is. And I'm hoping after my neurocognitive testing in February, I'll be able to get some more answers. I think I should stop there. And if people have any questions, I'd be more than happy to answer any questions. Again, thank you for your time. Thank you for the opportunity to share, and I'll stop there. Thank you.
All right, thank you so much. At particular time, if we have any questions from Members of our audience, if you'd like to raise your hand, you will be acknowledged. If you want to ask a question or make a comment, now's the time to do so. Thank you. While we are waiting for
Oh, my
questions.
hand is up. This is Melanie.
Yes, I didn't see it, Melanie. Go right ahead.
I want to thank you, Sylvester, for opening up about what you are going through and being completely honest. That's another point that we have to get across to people, is to be honest with themselves, because until they're honest with themselves, it'll be harder to get it across to someone else what it is that you're going through. And your vulnerability is so important for others to hear. The fact that you live alone and your automatic response is, let me isolate, so nobody will know what I'm going through. I'm glad that you're on the board of the Alzheimer's. It gives you something to do, to look forward to, and to step a little bit outside of yourself. And I'm going to call you, and I hope you accept my calls and that you will be someone who feels I'm able to, you can talk to. Okay,
Thank you,
thank you.
Melanie. Thank you, Melanie.
Thank you, Melanie, for the comment. Any other questions?
Yes, I agree.
Go
Have-
right ahead,
have a
Jerry.
comment.
Thank you. Go ahead.
I think you're doing all the right stuff, Sylvester. I was diagnosed with mild cognitive impairment a couple of years back. And the first thing I did was I was just out about it with everyone. I know it saved a lot of problems, just doing that. I'd also like to mention the Alzheimer's Association has some terrific YouTube videos that are very helpful. And the AARP has a really good bunch of stuff on cognition. You don't have to be a member. You can somehow join without being a member and have access to all of this wonderful stuff the AARP has for folks with cognitive problems.
Thank you.
Mhm.
Sylvester, I also want to thank you so much. We chatted a little bit before we started, and I expressed to you that it takes a lot of courage to be able to share, and we needed to hear that. My mother had Alzheimer's, and I wish that I'd been able to hear from her what she was experiencing as she was going through it. She got into a point where she couldn't speak, and she couldn't express to us what was happening. But you've given me insight into some of the things she might have been experiencing, and that's a wonderful thing. That's a gift and a talent, and I appreciate you for it. Thank you so much.
Thank you. One thing I do want to add, that early diagnosis is key, right? I feel, even though I'm going through what I'm going through, I feel really, really blessed, because no matter whether it's HAND or it's Alzheimer's, I found out early enough to be able to plan for my future. One quick thing I do want to share, and I got this from my friend Vanessa Johnson at the Positive Living Conference. She referenced an acronym called ICE. And the I is for independence. What kind of independence will I have? The C is who will care for me. And E is how will I embrace my current state? And that's something that I try to keep in the back of my mind all the time.
Question, Sylvester, about the embracing the current state. What words do you offer persons who may be experiencing something similar, whether personally or indirectly with a loved one? What words do you have for them given that statement?
I think the first thing is acceptance, right? Either what's going on with you or what's going on with your loved one, right? Because until there is acceptance, we can't move forward. This is something that involves action, right? And once acceptance occurs, action can take place, right? And to become educated as much as you can, and really take advantage of the resources that are available, and just know and understand that there are people out there who are willing to help.
My hand.
Go right
Hi,
ahead.
I just want to I just want to say thank you, Sylvester. You're very courageous in your openness and sharing, and I'm just so proud of you that you're moving forward and dealing with this. And this is helping a lot of people to realize, we can't just ignore it or just pay no attention at all. And the fact that you're actually working with the Alzheimer's Association, I give you a double applause because that's major. And as a caregiver for 4 relatives, I'm down to 1 now with dementia, and 9 relatives in my family that are siblings. My mother's had 9 siblings that also were diagnosed. I'm not, but because of that awareness and because of caregiving and because of loving the work that I do and working with you and others, that's still a call out, regardless of not having HIV or not, but embracing what is available. So I love the Alzheimer's Association and love volunteering with them. So I'm proud of you. I wasn't going to miss you today, Sylvester. And thank you, Katie, too. You did an awesome job.
Thank you.
Darkest, we
Yes,
have
Melanie, you.
one more question.
Yes,
I see
I
Lenny's hand
wanted
is up.
to thank Kate for a wonderful presentation. I spoke about Sylvester first because I really care about lived experience and sharing that lived experience. But what you presented was excellent, and I thank you for doing that.
That's very kind. Thank you.
Thank you. So that brings us to our closing. On behalf of Ribbon, thank you all for joining us today for this very important conversation. We want to express our deepest gratitude to our incredible panelists. If you could give the clapping emoji, if you can find that, we would appreciate it. They did a phenomenal job of sharing their experience, expertise, and perspectives. To our audience, thank you for your thoughtful engagement and participation. We hope today's session has provided meaningful takeaways and actionable insights that you can bring back to your communities and organizations. Just a few final reminders before we conclude. The session has been recorded. We will share a link later over the next day or so. And also a link to a survey was entered into the chat. We'd like for you to take a moment or two to share your thoughts and insights. The information you shared will help us moving forward and give us some insight as to what types of resources and educational opportunities that would benefit you most. Once again, on behalf of Ribbon, thank you for being a part of today's discussion and for your commitment to advancing health equity and HIV care. Have a wonderful rest of your day. Thank you.
Thanks, everyone.